Hi, everyone. Welcome to today's Center for Healthcare Strategies webinar, Bolstering Primary Care Through Medicaid Population-Based Payments, made possible through support from Arnold Ventures and the Commonwealth Fund. Next slide. On today's agenda, we are going to do some quick welcome and introductions, a presentation on developing primary care population-based payment models in Medicaid. We're also joined by folks from Colorado, Connecticut, and Massachusetts for a panel on primary care population-based payments. We'll have time for audience Q&A as well. And there's also a short survey that we're going to ask you to fill out to make sure that this webinar met your expectations. Next slide. So let's get started with that welcome and introductions. So today's speakers are from the Center for Healthcare Strategies, myself, Rob Houston, the Director of Delivery System and Payment Reform, and my colleague Ann Smithy, a Program Officer at CHCS, will be taking you most of the way through this webinar. We're also joined by the three folks from state Medicaid agencies that I mentioned previously. Araceli Sinestevan is the Alternative Payment Model 2, or APM2 analyst for the Colorado Department of Healthcare Policy and Finance. She has worked in the Payment Reform Division for 2 years on primary care value-based payment initiatives, bringing experience with stakeholder engagement and program evaluation to help support current and future models for Colorado Medicaid. She has a master's in public policy and administration from Colorado State University with a concentration in policy analysis. We're also joined by Dr. Brad Richards, who is a senior medical advisor for the Connecticut Department of Social Services and executive director of Yale Primary Care Residency Training Program. He received his MD from Georgetown University School of Medicine, an MBA from the Yale School of Management as part of the healthcare track in the executive MBA program, and completed an internal medicine residency and a chief resident year at Yale Primary Care Internal Medicine Training Program before joining the faculty in the Department of Medicine at Yale School of Medicine. It's a lot of medicines. Sabrina Wirtz has also joined us. She is the Senior Manager of Primary Care Strategy at Mass Health, Massachusetts Medicaid Agency, where she focuses on policy development and implementation for the agency's primary care subcapitation program. She received her MPH in health policy at the Harvard T.H. Chan School of Public Health. Thank you for all three of you for being here today. So for those of you not familiar with Center for Healthcare Strategies, we are a nonprofit organization based in New Jersey that is dedicated to strengthening the U.S. healthcare system to ensure better, more equitable outcomes, particularly for people served by Medicaid. We work in with Medicaid agencies, Medicaid providers, Medicaid health plans, dually eligible health plans, and increasingly consumers and consumer-based organizations to help those served by Medicaid to get the best possible outcomes. Next slide. So I mentioned we're here today to talk about population-based payments. So it's probably helpful to understand what a population-based payment is before we start talking about it. And you'll see a lot of different definitions out there, but the one we use at CHCS is the one on your screen. It's an upfront, prospective, value-based payment model that includes provider accountability for both quality and cost of care. This can be used for primary care, which we'll be talking about today, but also for hospitals, total cost of care models, and other value-based payment models. The key features of this model is that the payments to the providers are based on the number of empaneled patients, not the number of services performed. So this is moving as far away as you can from the fee-for-service traditional model of paying for visits. It's basically paying a provider to keep a member well rather than treat them when they're sick. Another key feature, and this is what separates a population-based payment model from a capitated model, they're a very similar payment structure, but you must hold providers accountable for quality. If it's not quality-based payment, it is not a value-based payment, it's not a population-based payment, it's just capitation if you're paying a per member per month model upfront. So we also classify population-based payment approaches as either a hybrid or a full population-based payment model. Next slide. So we have a illustration here that talks about full and hybrid population-based payments. So there's 3 columns here. On the left are things that have more incentive for volume and less risk attached to them. And by risk, we mean financial risk. And on the right, we have more flexibility and also more risk. So you see the blue boxes here. A hybrid PVP is the one in the middle, where you have a fee-for-service payment that is around half in this graphic. It could be a different amount. That is fee-for-service, and half of it is a population-based payment that partially replaces that fee-for-service payment. A full PVP, which is all the way on the right, replaces all the fee-for-service payments with a population-based payment paid prospectively. All the way on the left is the fee-for-service payment. And there are sometimes some supplemental per member per month payments attached to that, but it doesn't affect the fee for service. It's still fee for service, but there's what's commonly called a care coordination fee that is on top of it. It's actually more than the fee for service would have been. So there's not any kind of replacement of fee for service there. I should note, and it's in there in a small font there, this is not a value-based payment. It's not a population-based payment. It's just a supplemental payment for care coordination. There is some value to that, but it's not what we're going to be talking about here today. Next slide. So there are some benefits to pursuing a primary care population-based payment, and there are also some challenges. So I'll go just at a very high level here, and we'll get into some of the details in the decision-making process shortly. But some of the benefits I wanted to highlight are it moves away from value-based incentives inherent in fee-for-service. If you know the healthcare payment and payment learning and action network framework, it is all the way to the right. It's the most advanced model. It is where you want to go for value-based payment in terms of moving away from fee-for-service. It provides budget stability to payers. You know how much you're going to pay the provider that's participating in this primary care model. It also provides financial stability and predictability to the provider organization receiving the payment. You don't have to be on the hamster wheel of chasing more services to make more money. You know how much you're being paid and you can budget accordingly. It also increases the flexibility in treatment and staffing decisions. You don't have to worry about which codes you're billing. You just provide the care the member needs. It also includes a link between payment and quality of care to make sure that there is higher quality care is being delivered. There are some challenges, though. There is limited existing examples and evidence base. We do have 3 panelists that are going to be able to talk about their examples today. There are challenges inherent in designing and implementing any new payment model. There's a learning curve for providers. You try to get it right, but it's going to have to be iterative over time, and you're going to have to work out the kinks. That's something that has to be dealt with. It also creates an incentive, a very real incentive, to withhold needed care. If you're going to be your provider and you're going to be paid whether or not you provide care or not, there's no financial incentive to actually provide the care unless there is a quality metric that is associated with it, which is why the quality metric is critical. Now, it doesn't mean just because there's a financial, not a direct financial incentive, doesn't mean that providers are going to withhold all care, but there isn't a incentive in place to provide more care. It also requires a new way of doing business that may take time for provider organizations to adopt and figure out. That's the learning curve I mentioned a little bit earlier. Okay. So that's a very quick overview of primary care population-based payments. And if we move to the next slide, I will hand it over to my colleague, Ann Smithy, to talk about population-based payments further.
Thanks, Rob. And hi, everybody. So good to see you all here. Really excited to talk to you more about the work we've been doing on primary care population-based payments, and then eventually we'll hear from our panelists. So I wanted to start just by giving you a little bit of context about what's going on across the country with primary care population-based payments. And as you can see from this slide, it's an increase in sort of national interest. So on the next slide, you'll see that, like Rob mentioned, there's a bit of a limited evidence base when it comes to primary care PVP models. Not a bunch of them have been launched, especially by public payers who share a lot of information about their design, their outcomes, and what's going on. But we also know there are a lot of models that are in the early stages of design and that there's a lot of interest in primary care PBPs across the country in Medicaid, which is what we're talking about today, but also in Medicare and by commercial payers. So innovative states have designed and in some cases already launched these types of models. We'll hear from panelists from Connecticut, Colorado, and Massachusetts today who have been working on their primary care PBPs. And we also know there's work going on in New Mexico, Oregon, Washington State, and others. And there's also a lot of interest coming from the federal government on primary care PBPs, in particular through CMS Innovation Center models. So Rob shared kind of the difference between hybrid and full PBPs, and we see both of those being tested out through the Innovation Center. They started with track 2 of the CPC Plus, Comprehensive Primary Care Plus model, and then later the Primary Care First model, both of which tested hybrid primary care PBPs and gave us a chance to try them out and try them out in a multi-payer way. There's the new Making Care Primary model, which includes a pathway to hybrid and full PBP models, which will be operating in 8 states and is kind of just starting to kick off. I saw just a few days ago that providers announced their participation in the model, and it looks like we're going to have a lot of good interest across the country, including lots of small providers and FQHCs participating, which is really exciting. And then a few other Innovation Center models show that there's some interest in incorporating primary care PBPs into broader or bigger payment reform efforts. So the AHEAD model is looking at primary care models as well as hospital global budget models. ACO Primary Care Flex is a full ACO model, but has a primary care PBP component within it. So from all of this, we can see that though it's still on the earlier side for understanding exactly what's working and how it's going with primary care PBP models, there's a lot of interest, and states and other payers across the country are really in some early stages of thinking through what they might want to do to design a PBP model, what their goals might look like, and kind of how they'll go about really getting started with this. And so with that in mind, we're going to be really focusing on some of the earlier stages of designing PBP models and how they can bolster and promote primary care in your state. So we'll go to the next slide. So first, I'll start just giving an overview of what it takes to design a primary care PBP model. We recently wrote a piece about that, which we'll link to at the end of the webinar. It'll be linked in the slides, and kind of explored 6 key topics in primary care PBP model design that are important for states to think about if they're going to pursue a model like this of their own. Those include setting goals and deciding the scope of your model, which providers, patients, and services are incorporated. I'll talk a lot more about those, which is why they're highlighted, and I'm not going to spend as much time on them on this slide for that reason. There's also the payment approach, right? How will payment move from the state to the payer if you're a fee-for-service state, or from the state to the managed care organization and through to the provider if you're a managed care state. There's thinking about attribution. How will certain patients be assigned to certain providers for the purposes of calculating payment rates and holding providers accountable for quality of care? There's questions around rate setting. How will you decide how much payers or providers get paid? Will it be based exclusively on historical care delivery? We'll try to calculate some kind of measure of ideal primary care to shift care delivery patterns to more equitable and value-based care delivery. And we'll look at social risk adjustment, which is a topic I think that has been very interesting and quite well explored in the recent past few years. And then last but not least, a lot of decisions need to be made around what kind of care delivery standards are incorporated. We're not just doing primary care PBP models because we think it's fun and interesting to pay differently. We're doing it because we want primary care to be better, to provide a better, more personalized and more flexible care to our patients, and because we want our providers to sort of know what advanced high quality primary care looks like and have the resources and the support to get there. So thinking about what kind of standards there are for care delivery and what kind of accountability there is for providers to meet standards is another important question to explore. But like I said, we'll focus on the decisions that kind of need to be made earliest on in model design, knowing that for many people in the audience today, that's where you are, and that's model goals and model scope. And on the next slide, we're going to talk about 3 other sort of additional considerations for designing models that are explored in the primer. One is engaging with model stakeholders, which is a really critical piece of creating an effective model that has a lot of buy-in from providers across the state. Again, that's a highlighted one I'll talk about a bit more. But there's also considerations around designing models for providers who face specific barriers to participation. Providers who work at FQHCs, work in small, rural, or remote practices, who work in Indian healthcare programs. All of these providers are typically less likely to participate in value-based payment. And when we design models that don't fit their needs, we're not making sure that those models are able to care for and change care for the patients who need it most. And then the last thing that's an important consideration we explore in the primer is considering opportunities for alignment with other payers, as well as with existing or new payment or quality improvement models within the state. So we know there's a lot going on out there. Every payer's got their own ideas about how to design effective primary care models. Every state has a lot of different and far-ranging initiatives to improve healthcare, promote well-being, and improve quality. And to the extent that you can design primary care PBP models in alignment with what else is going on, you can have a greater impact and better outcomes for your patients and for your providers. All right, so I highlighted sort of 3 areas we'll focus on that come earlier on in the model design process, as well as some other topics to keep in mind that are explored in other resources on the CHCS website. But we'll jump in now to model goals. So when you think about setting goals, I think it's really important because it can sometimes feel like a bit of a basic concept to realize how important setting clear and effective goals are. And that's because model design choices, the ones you make around scope, payment approach, attribution, rate setting, and care delivery standards, should always refer back to the model goals you created. So thinking long and hard about what are the actual goals is kind of the first step to creating an effective model where each design choice you make feeds into each other, references each other, and works together towards your common goals and your common priorities. So on the next slide, we'll think a little bit about what good model goals look like. Model goals create a vision, they guide the design of your primary care PPP model, and they define what success looks like in your model. And it's really common for states to have goals when it comes to value-based payment. And they're often goals that look like the triple aim and the quadruple aim and those other things, right? Things like improve quality of care, promote population health, promote equitable care. And those are really good goals, and they're obviously the driving force behind payment reform and what we're trying to do with healthcare payment. But they're also kind of vague, and it can be difficult at times to really measure, how we're doing on meeting those goals, and it can be difficult to apply those goals to model design choices. So it's really helpful to think about narrowing down onto a couple of key goals, 2 or 3, that can help you in the state target your limited resources effectively. You, if you're a payer, or you, if you're a provider participating in the model, also can use the goals to target your limited time and resources effectively. Goals should be specific and measurable to make it easy to understand if you're making progress towards your goals, or if you're not, and how the model might need to change over time to meet goals. And finally, in an ideal world, your model goals are linked to bigger picture agency priorities. Kind of going back to what I talked about on the last slide, alignment with other initiatives across the state. So we'll talk about 2 of those priorities on the next 2 slides, the first one being cost control. So like I said, there's a lot of sort of pre-existing goals inherent in value-based payment. And a really big one for that is decreasing the really high cost of care in this country. But if you have worked in primary care for a while, you've probably heard this before. Primary care is typically really underfunded in the US, and that limits our ability to deliver effective preventative care, system-wide cost savings, and strong care relationships. So with that in mind, it's interesting to think about when you look at primary care PBP models across the country, what existing models look like and what model designers are talking about and thinking about. It's quite common for these models to actually focus on increasing investment in primary care rather than controlling cost in primary care through it. I think this is kind of counterproductive or counterintuitive to think about at times because many PBP models at the hospital level or the total cost of care level really are focused on cost control. But in primary care, many states and payers have taken the opportunity to create a PVP model that comes with a rate bump or new forms of revenue for primary care providers. And an example of sort of a specific, measurable, clear goal related to this would be the one I have in the box on this slide. Increasing investment in primary care by raising rates for participants in the PVP model to 100% of Medicare rates within 3 years. So you can see that meets this cost control goal, or it meets this cost-related goal of primary care investment. It can tie to broader state priorities around system-wide cost savings through more preventative care and less acute care. And then it's a clear, specific, and measurable goal for the primary care PVP model. On the next slide, we'll talk about another common state or agency-wide priority, which is promoting or improving health equity. So states are really focused on developing programs that lead to more equitable care and health outcomes. And we know that primary care as the entry point into the healthcare system, as the area where providers and patients often have strong long-term and ongoing relationships, and as the area that focuses really on preventing poor outcomes rather than just treating them once they've happened, can be a really key part of health equity strategies and achieving and attaining more equitable health. Different states might approach health equity goals in their primary care PVP in different ways. They might develop specific health equity or health disparities goals, say looking in gaps or disparities in certain quality measures or types of care by race, by geography, by language spoken. Or they might develop goals that are focused on specifically on populations who experience specific health inequities. So they might say, diabetes is a problem in our state that disproportionately affects people of color, and it's an area we really want to focus in order to improve health equity. So again, health equity can be a really big part of a primary care PVP model and can be incorporated into a couple of those big model-wide priorities, the 2 or 3 key priorities I talked about earlier. On this slide, we have another example, this one related to health equity, which is promote equitable primary care by requiring adoption of team-based care models within 3 years of model launch. So again, this might not always look like some of the more common goals you see when you're thinking about the triple aim or the quadruple aim, but it really looks at a measurable thing, adoption of team-based care models, a specific time period, and an overarching philosophy behind it, which is to improve equity. All right, so we'll move on from this slide onto our last slide in the setting goal section, which is thinking about evaluating progress on model goals. Just really a quick note here, which is that we know resources to evaluate primary care and VBP programs are really limited at the state level. It can be hard to find the time, the resources, and the expertise to do so. And evaluating healthcare interventions, like in and of itself, is just a pretty difficult task. But at the same time, it's really critical to think about if and how you can evaluate your models. And having clear model goals is sort of the first step to doing that. Knowing what you're trying to achieve is what you need to do to see if you're achieving it. There's interim evaluations that can look at early indicators and what's going on so far, and longer term evaluations, which account for the fact that we know changing care delivery and transforming primary care is going to take a lot of time, and that evaluation can also operate on that longer time scale as well. And then plans for evaluation should ideally be developed before the model is launched, kind of in tandem with developing model goals to help collect baseline data and identify what data is needed to assess success. And a final note on evaluation is that, in an ideal world, we have robust, academic, high-quality evaluation, but we know that's not always realistic for the kinds of constraints that states and others are working within. And so it's just good to remember that any evaluation is valuable and that different types of data, including qualitative data, experience of care, provider experience, can all be really helpful for assessing if you're meeting your model's goals, or at least working towards them over time. All right, so now we'll move on to thinking a little bit about model scope, which is one of the other key design decisions that you'll need to be thinking about in designing a primary care PVP model. So again, on the next slide, we'll talk a little bit about defining primary care. Again, if you've worked in the primary care space for a long time, you may have seen these definitions before. They're pretty widespread now. There's a lot of different reasons we need to define primary care, whether that's measuring spending or designing programs like a primary care PVP model. You can think about defining a key set of services as primary care services, regardless of who delivers them. You can think about defining certain providers as primary care providers, regardless of what services they're delivering. Or you can do kind of the most common approach, which is combining the two. Some specific services delivered by some defined set of PCPs are considered primary care. And when you're designing a primary care PBP model, you kind of have to think about what services fit within the PBP, what are we considering primary care for the sake of this model, which providers are eligible to participate, who are the PCPs that are going to be paid through the population-based payment, and finally, which patients are going to be involved. Are there certain populations or subpopulations we want to include? Like, will this model account for pediatric care, or is it focused exclusively on adults? On the graphic on the screen, I have one example of a provider-based definition of primary care. There's a narrower one, which just includes the 4 specialties you see, and a broader one, which includes those types plus NPs, PAs, gynecologists, people with focuses in geriatrics or adolescents. This kind of narrower to broader spectrum can apply to any definition around the scope of the model, right? You can have a model that's more narrow, defined and specific, or a model that's more broad, more expansive, and includes a wider swath of patients, providers, and services. So on the next slide, we'll think about kind of different questions that you can ask yourself when defining primary care in your setting. And that includes, are there specific populations, providers, or services that you need to include in your model to meet your goal? Kind of obvious, but if your goal is really focused on improving health for families, then you might want a model that addresses not only adults, but pediatric care as well. You want to think about broader versus narrower, or more or less expansive, as I just talked about. You may want to think about alignment with other models that are going on in your state, whether those are innovation center models, commercial models, or others. You may want to think about which stakeholders you should talk to. A really common issue that comes up in defining primary care is whether OBGYNs are PCPs. It's an interesting question, and the answer can go, multiple ways depending on what you're trying to do with your primary care model. But it's also pretty important to know, do OBGYNs in your state think of themselves as PCPs? And that can be a really big guide to answering this question effectively. And then finally, Rob mentioned at the beginning the incentives for volume inherent in fee-for-service, and that there's less incentives for volume in PBPs. One question around scope of services and scope of your model is, are there specific services where you want to incentivize volume? So this is just a handful of questions that can be really helpful for defining exactly what primary care means in your primary care PBP, and how you and others who are working on your models with you are defining the scope of your model. All right, so we'll move now to the last piece I'm going to talk about in my presentation, which is engaging with model stakeholders. So we can skip to the next slide. There are a lot of different stakeholders who are going to be impacted by a new primary care PBP model. The practices and providers, patients and their families, managed care plans if you're a managed care state, non-Medicaid payers if you're working on a multi-payer model, people who are interested in model design who sort of have a vested interest, right? Advocacy organizations, whether that's a provider organization or a patient advocacy group, and professional associations that speak on behalf of these kinds of stakeholders. So you might have kind of a wide circle of people who are really interested in being involved in influencing where the model design goes. And on the next slide, we'll talk a little bit about the value of engaging with stakeholders. So Medicaid goal, or the model goals, should be designed in partnership with your stakeholders, and that includes Medicaid members who have their own goals, insights, and desires when it comes to care delivery and primary care transformation. And when you engage meaningfully with stakeholders from the beginning of model design and throughout model design, you'll see a lot of benefits, even though it might make for a longer and maybe sometimes more complicated model design process. Those benefits can include creating a model that really addresses specific issues faced by plans, providers, and patients in your state. Addressing those issues will lead to an improved model design. Working together to set goals will make mutually understandable goals that resonate with all your stakeholders. And all of these things will hopefully lead to increased buy-in to the model and increased likelihood of participation. So spending the time to really build trusting long-term and ongoing relationships with model stakeholders, letting them substantively weigh in and help influence model design. All of that can be helpful and create a model where you put something out in the world and people actually participate in it and you actually see the benefits you're hoping to see. All right, so we'll just move now to my last couple of remarks before we kick off the panel. So key takeaways that I want to really emphasize from today's presentation are that many states are in the early stages of ideating and designing primary care PPP models. So we really wanted to focus on some of the earlier decisions you have to make during model design. And those include setting goals, defining the scope of your model, and engaging with model stakeholders early and often to define a model or to design a model that really resonates with people and stakeholders across your state. So we'll move now into the panel, but before that, I just wanted to remind you, you can always go to our website, chcs.org, which includes the primer, which influenced a lot of the discussion we had today, and also has a lot more discussion about the 6 areas that I talked about at the beginning of my presentation, and then other resources related to primary care PPP models. But for now, I want to move into the panel for the second half of our time together today. So I'll welcome onto our panel Araceli Santa-Steven, who comes to us from Colorado, Brad Richards, who comes to us from Connecticut, and Sabrina Wirtz, who's coming to us from Massachusetts, to talk to them a little bit about the work they've done in their states regarding primary care PPP model design. So welcome, Araceli, Brad, and Sabrina. Super glad to have you here. It's been great working with you over the last year and a half and then sharing what we worked on together with our audience today. All right, so thanks. So just going to start with some level setting. Can you each please provide a brief overview of your primary care PPP model, kind of what it looks like or what you're hoping it will look like, and where you're at now? And Araceli, I'll start with you. Go ahead.
Absolutely. Good afternoon, everyone. So APM2, or Alternative Payment Model 2, as the name suggests, is sort of our second primary care value-based payment arrangement in Colorado. It sits on top of the framework of what we call APM1, a pay-for-performance model where practices can select and report on a set of quality measures. They're then scored on those measures, which determines a small fee-for-service rate adjustment. APM1 is the quality model that APM2 sits on, and APM2 has 2 main components. The first is a prospectively paid per member per month rate, which replaces part of a practice's fee-for-service revenue based on what percentages they select. Practices can select anywhere from 0 to 100% PMPM, with the remainder paid out as fee-for-service. The second component of APM2 is an upside-only shared savings opportunity for management of 12 chronic condition episodes of care. That's sort of the overview of the current state of the model. We are also currently in the process of evaluating and redesigning these models, both APM1 and APM2, to better align, with other initiatives at the department, including the development of a pediatric-focused model.
Great, thanks, Araceli. Sabrina, I'll go to you next for Massachusetts' model.
Sure, thanks, Anne. So we launched our primary care subcapitation program in April of last year, so we're about a year and some change into implementation. And the theory of change for our program is really by implementing payment reform, we hope we can change how care is delivered and down the line actually improve population level health outcomes. Our program actually sits within the broader accountable care organization framework that we have in Massachusetts, and our ACOs are accountable to quality, member experience, and total cost of care. And all primary care practices in an ACO are required to participate in our primary care subcapitation program. We have about 1,000 practices in our program right now. And if a practice does not want to participate in, for shorthand, the subcap, that's completely fine, but that also means that they cannot participate in our ACO model and instead have to participate in a different Mass Health product. Our program also has a tiered clinical structure. So we have 3 clinical tiers of participation, a tier 1, a tier 2, and a tier 3. And the higher tiers have greater primary care delivery expectations, but those tiers also come with correspondingly higher payments. And then just a quick note on rates. Our rates are PMPM rates that are actuarially developed. They, for year 1 and year 2 of the program, are based on historical practice-specific utilization. But for year 3 of the program, which will start in January of 2025, we're actually moving away from that and towards a population-based rate that will be prospectively risk-adjusted.
Great. Thanks, Sabrina. And apologies if you mentioned this, but just to make sure it's totally clear to the audience, your primary care providers are paid fully through a PBP. There's no fee for service if they're participating.
Correct. We're a full PBP.
Great. Thanks, Sabrina. All right, Brad, we'll go ahead to you.
Thanks so much. I think Connecticut, we're in a different place than my colleagues in Colorado and Massachusetts. So we've been working on reform for since 22 and recently finished our preliminary design work. And we've laid out an overall structure that is really a 3-track primary care program. And that does include FQHCs, rural health clinics as well, and has a PBP option, but is not the only option. Along with flexible funds and for the smaller providers, P4P program, and for larger shared savings. And so again, we're kind of in this, the first phase or finishing the first phase of design. And we really did this, got to this place by answering a bunch of key stakeholder questions and working with some stakeholders to kind of get to where we are. And so we can get into that maybe a little bit more, but I'm happy to lay out kind of some of that work today, because I know we're in a bit of a different place than the other two states. But we try to answer these key questions. So 4 of them were, what are the key things that primary care should be doing differently or better to improve member health and well-being? What's the definition of success? How should this be measured? And how is primary care paid and incentivized for doing things that improve member health and well-being? And how do we address inequities and racial disparities as part of this process? So we use those to help get to where we are. And then there's a planned subsequent technical design phase to really get into the details and outline further exactly how this will operate and those key details that are needed for implementation.
Great. Thanks, everyone. That's really helpful kind of context just to know both, like you were saying, Brad, where you all are in the design and refinement stage of your model, as well as how, though you're all doing something we're calling primary care population-based payment, that's the same. It's also very different. There's flexibility, there's multiple tracks, there's, a broad overarching model on top of some of your models. So really interesting to remember how personalized this can be to your state's context. All right, so I spent a lot of time talking about setting goals and thinking about really specific and defined model goals. And so while I know you all had a lot of different things you hoped your models would achieve, it would be great from each of you to hear, if you had to narrow it down to your top 1, 2, or 3 goals, what would those be? And how have they impacted your model design to date? So Sabrina, I'll start with you.
Sure. Yeah, definitely a lot of goals of our program, but if I were to narrow it down to 3, I think the first is really just getting practices and providers off of the fee-for-service treadmill and really giving them the capability to provide what they think is the right care at the right time at the right place. We know that if providers continue to be incentivized to bill 15-minute office visits or individual widgets, we're not going to get where we want to go, and we won't be able to improve the experience for providers or members. Another really important thing to us that you touched on, Anne, is elevating the financial support that we're providing to primary care practices. We know that primary care is the backbone of the healthcare system, and that it's been a very challenging financial landscape for primary care practices. And we're addressing this through a number of levers in our program design. So obviously through the capitation structure, we hope to provide revenue stability. But we're also investing an additional $115 million per year through our clinical tier add-on payments. In year 2 of our program, we did a targeted rate increase for our group practice organizations who are particularly struggling in our state. And we have an overall commitment to increasing primary care spend as a % of TCOC. So that's a really important goal for us. And then of course, elevating team-based integrated care is the key goal, especially as related to behavioral health. We know that our primary care doctors can't do it alone. Team-based staff like CHWs, family partners, behavioral health staff are really crucial to providing that whole person, high-quality primary care that's so important for patients. And you'll see our dedication to the team-based model reflected in our clinical tier requirements.
Thanks, Sabrina. Araceli, I'll turn it to you for your goals of your model.
Yeah, definitely. So one of our biggest goals throughout the development of APM2 was to create a level of revenue stabilization and consistency for our primary care providers. Our model was in development during COVID and launched in 2022. So in the aftermath of the worst days of the pandemic and the uncertain utilization patterns it created, that definitely was top of mind for our model design teams. A secondary goal was to create additional flexibility for providers and how they adopted a value-based payment or a population-based payment opportunity. We operationalize this by allowing flexible enrollment dates and differing levels of participation. So what I mean by that is practices can join the model on a rolling quarterly basis, and they can choose any level of PMPM, as I mentioned, between 0 and 100%. The model right now is voluntary. And practices can phase into the model by adjusting their level of participation over time. So for example, they could start out with no PMPM or a very low percentage, just focusing on the chronic condition shared savings opportunity. And over time, add that PMPM percentage or increase their level of reimbursement through that side of the model. And another goal that we wanted to emphasize throughout this process was reinvestment into primary care, similar to what Sabrina was describing. In Colorado, this took the form of a 16% rate increase that is attached to the PMPM. So practices who elect a PMPM percentage of 25% or higher receive the full amount of that rate increase with a prorated amount below that rate. And that number, that 16%, was adopted as a number we identified as bringing us closer to parity with Medicaid rates in our primary care setting. On the shared savings side, we had identified the 12 conditions that we're currently targeting as some of the highest drivers of costs in Colorado. And we wanted to create additional incentives to target avoidable expenses and redirect utilization from the more expensive care like ED utilization into the preventative services in the primary care setting where possible.
All right, thanks. And then Brad, I know you talked about some questions you all asked yourselves in model design. Anything you'd add on the goals and what success looks like to you?
Yeah, we did. We were obviously in a different phase in terms of, I think, having goals. And I think, having been through other payment reform, our goals are a bit more broad to begin with. And I think we would be in this next phase really trying to narrow it down as we've done subsequently and tying specific measures to those goals. But at this point, we haven't quite reached that phase. So our overarching goal for this work was very broad, and it's to improve the biopsychosocial health and well-being of Husky members, so Connecticut Medicaid and CHIP members, especially for those most historically disadvantaged in a way that reduces inequities and racial disparities. So, I suspect those very broad goals. And then we also just acknowledged as part of this process that primary care is not going to be the be-all, end-all to do all of this. So both recognize the importance of that broad goal that applies across both outside of Medicaid and CHIP and within it, and acknowledging that primary care can start to maybe address some of these historical inequities, but is not going to be the major driver. So we acknowledge that. And then we also laid out some strategies to how we might start working through that and to achieve it. So one is a few of those strategies, including like just incorporating health equity as a guiding principle for system access, upholding a model of mutual accountability, maximizing the program impact by really trying to participate in other reform efforts and trying to align measures and payment as much as possible when practical. And then using data, evidence, and member experience to inform what we are doing along the way. So we use kind of this very broad overarching goal, really tried to use some strategies to help inform it. And then we, as part of our design process, really used a cross-cutting equity strategy, which we can, if helpful, get into later in terms of how we thought about that. Just making sure that we were, I think this has come up in some of the work that we've worked with and with you and others on is, the data on how to incorporate health equity. We're so early to figure out what are the best practices. But if we don't incorporate anything, we're going to not make any changes really, because or probably we're going to miss the mark potentially from what we're looking to do. So making reasonable choices with stakeholders involved to figure out what those changes can be now that we can measure and see what that effect is. So I think we use this to kind of drive our process forward with our stakeholders. So I'll stop there and happy to follow up further if helpful.
Mm-hmm. Thanks. I really appreciate hearing the goals that you all have, because they are, again, like very different, but a lot of consistency around bolstering the primary care system, which is kind of what we're really focused on today, and different ways to strengthen primary care, improve provider experience, and gather engagement. I'll make a quick note here. I've seen some great questions from the audience that we'll get to in just a couple minutes, but audience, please feel free to keep submitting questions to us in the Q&A box at the bottom of your screen. We'll do our best to get to the ones we can. I wanted to make sure we touch on one more topic before moving to the audience questions, which is stakeholder engagement. And we've been working with all of you for the last 18 months or so on your primary care models, and we've talked a lot about how you can incorporate stakeholder feedback and make sure they're really involved in designing your model alongside you. So I would love to hear from each of you a little bit just kind of about the process of how you engaged with stakeholders and what that looked like for designing your primary care PVP models. So Araceli, I'll start with you and see what you have to say about Colorado's work.
And this is one of my favorite parts of the work that we do to bring these models live. In Colorado, stakeholdering is definitely a big part of our process. The original development and iteration of APM2 had a very robust process that included listening sessions for providers, advocates for providers and patients, as well as Medicaid members themselves. We also recruited a diverse model design team that participated in 7 intensive workshops in the lead up to the rollout in 2022. And also supported beyond that date. Throughout our initial launch and implementation, we've continued to work in very close partnership with our model participants. We meet regularly with the early adopters to get feedback on their experience to date. We also meet with providers who weren't quite ready to join to get a better sense of where the pain points are and what supports they need to consider adopting the model and to more generally scale this model up. As a part of the redesign and evaluation work I mentioned at the beginning of the panel, we have initiated a similar design review team process. In this case, we've been meeting twice a month since January of this year with a similarly diverse group of stakeholders made up of Medicaid members, providers participating in and waiting to join the model, as well as members of our regional accountable entities, which is a group that operates under our Accountable Care Collaborative within the state, advocacy organizations, and several other stakeholders. This process is also being used to support the development of the pediatric model that we're considering. Overall, we've received really positive feedback on this approach, and it's allowed us to get a lot of really in-depth insights into what improvements we can make into our existing APMs to continue to move further into this population-based payment space.
Great. Sounds very robust. And you and Brad have both brought up things I want to touch on later, pediatrics, which is an audience question, as well as health equity, but we'll just spend another moment on stakeholder engagement. Brad, I know you mentioned a lot of stakeholder work and you've told us some about it already, but is there anything else you'd like to add to how your primary care stakeholders have informed model design?
Yeah, I would say quite extensively. We have existing stakeholder, I think a lot of states have existing stakeholdering processes in place for both with legislatures and community members and advocates. But we did put in place additional specific stakeholdering processes for this. We designed a primary care program advisory committee that we had been meeting with regularly throughout this process and included members, various stakeholders throughout the state government and advocates, really try, and as well as providers, to get a diverse group of perspectives. And so I think that's been extremely helpful in shaping the process, and they've pushed back against how we've been approaching it. And I think that's been valuable in terms of both getting buy-in, but also strengthening what we're looking to do, getting that feedback. And then we had a subcommittee with FQHCs, just because of the importance of that stakeholder process. We had a subcommittee that incorporated FQHCs that were willing to participate. And then we, again, had a member advisory committee that exists through our administrative service organization that we also tapped into to make sure we're getting additional member voice. And I'll just note that as part of a kind of pre-work process, we did some focus groups, which gave us a lot of really valuable information and helped shape some of those initial goals that I mentioned previously. So we did some kind of pre-work, so to speak, with stakeholdering that we then used to turn into broad goals that we use to help shape the subsequent stakeholdering process. So kind of an iterative process, really grounded in stakeholdering throughout.
Great. And then Sabrina, I know it looks a little different in Massachusetts because you have that subcap sitting within the ACO structure. Is there anything you'd like to add or share about strategies you used for your primary care model?
Yeah, I mean, just to echo, our stakeholders are really critical thought partners, but it does look a little bit different for us because of our ACO structure. So sometimes we engage directly with primary care practices, but there are just too many for us to realistically meet with. So the ACOs, when we engage with them, are really representing both themselves and their practices in regular conversations with us about the operational requirements of the primary care subcap program, but also in conversations specific to rate setting methodology and risk adjustment methodology. Those meetings happen often, and they're very collaborative and iterative. And I think we attribute a lot of the success of the program to offering those regular opportunities for the ACOs to engage with us on model design. We have other stakeholders as well, advocacy groups, the state legislature, nonprofit organizations, and we also recently launched a technical advisory committee that we're able to turn to for feedback and advice. And of course, we have internal stakeholders as well. They were really critical partners in setting up the processes to make a PDP program run.
Awesome. All right. Well, good to hear too about, the value of the stakeholders in influencing your model design. So we have a question from the audience now for you, Araceli. I don't know if you know off the top of your head, but what % of PBP have you seen practices select, given that you have that really wide range of options and flexibility?
Yeah, I don't have the exact ratio off the top of my head, but what I will say is what we generally see in terms of model adoption is practices either join just focusing on that chronic condition incentive payment, so 0% PMPM, or they join at 100% PMPM. We have a handful that have taken advantage of the opportunity to adopt at a mixed fee-for-service PMPM. I think 50-50 is the most common. But that's generally the way the distribution has fallen. And I think at the moment, we're fairly evenly split between the chronic only and the folks who have gone, as we say, all in and are full model participants.
Mm-hmm. Okay, thank you. And then for all of you, I think you've all thought about this to some extent. From the audience, please share your thoughts on PBPs in pediatrics, and in particular ways we can increase interest among pediatricians for these kinds of models. So I don't know if one of you definitely wants to start.
I'd love to if the other two are okay. Yeah, so as I've alluded to, we're actually actively developing a pediatric specific model in Colorado. And this has been driven largely by the existing interest and engagement that we have from our pediatric stakeholders and pediatric providers. In particular, feedback that we've heard that the capitation model, the per member per month model, may not be as accurate of a replacement for fee-for-service for pediatric providers, given visit volumes for younger patients, as well as the fact that the chronic conditions that we're looking at are not as common in young patients. We've obviously worked very closely with those stakeholders and gathered a lot more feedback, but just at a high level, that's what we're hearing. And so what we've been doing moving forward is engaging, as I said, in a design review team process that is a specific breakout just for those pediatric providers and their considerations to make sure that what we're designing is thoughtful and responsive to that moving forward.
Mhm. Thanks. Yeah, and it's been great to be along for the ride a little bit, hearing about your pediatric work. Brad, did you want to add anything?
Just really briefly, that we've been very explicit that we're trying to set kind of a base payment model, and then similar to what was noted is really build off of that as needed for things like a pediatric population where this may need to be tweaked to be most effective.
Mhm.
And just to add for our model, we cover both pediatric and adult practices. So both of those types of practices participate in our model. In our clinical tier requirements, we actually have some requirements that are specific to pediatric practices, things like having a staff member with children, youth, and family expertise or designated educational liaison. So we do really try to take a family-centered lens in our clinical tier requirements. And we also have what we call our tier add-on payments, which is the amount that gets tacked on to their prospective capitation rate based on what clinical tier they attest to. And those actually vary by whether the member is a child or an adult. And the amount for children is higher than adults. And that was a design choice we made just to reflect how important it is to invest in preventive care for children and youth.
Great. Thanks for that answer. All right, and one other question from the audience. We've talked a bit about, one of the goals of the primary care PBP is to increase flexibility and to be able to personalize care. And of course, part of that includes developing care teams and more sort of holistic primary care. So what kinds of non-clinical, non-traditional, or unlicensed providers like CHWs or others are part of your teams and your models, or sort of how does that interact with the primary care PBP models you all have been working on? Again, happy to have anyone start.
I can start.
Mhm.
So we've got 3 clinical tiers, tier 1, tier 2, and tier 3. And tier 2 and tier 3 is really where a lot of our team-based staffing requirements come into play. What comes to mind is, it actually is called the team-based staffing requirement in our document. And we're encouraging practices to bring on community health workers, family partners, peers, LMFTs, LICSW. So really, like, we offer a lot of flexibility in the types of team-based staff members that a practice wants to bring on, because we don't want to be overly prescriptive, since the practices in our program are very varied and have diverse needs. So actually, all of those are options for a practice to begin to develop team-based integrated care.
Mm-hmm. Okay, so lots of flexibility within sort of a broad requirement. All right. Araceli, Brad, anything you'd add?
I'll just say, since we're still in this, we haven't gotten to the detailed design, but as part of our cross-cutting equity strategy is, what is primary care? One of the questions, what does primary care need to do differently to improve member health and well-being, is to the incorporation of community health workers, which was one of the very early things that came up very loudly and clearly. And so that, as well as the requirements for having kind of comprehensive competencies for individuals with disabilities and team-based care. So there's been a lot of the team-based care discussion about what that will look like, but we're obviously still working on some of the details. But I would say clearly community health workers and the need for a robust care team is very much at the forefront of the conversation.
Mm-hmm. Great. And Araceli, anything you'd add?
Yeah, I'll just quickly say that it's very much at the forefront of some of our conversations and the redesign and design processes that we're undergoing right now. In particular, we're trying to come up with more robust ways to track and see those additional services to make sure that we're fully incorporating them into our model design considerations.
Great. All right. And thanks for going fast. I know we all have an eye on the time, and an hour really flies when you're talking about primary care and population-based payments. So I'll wrap up now. So Brad, Sabrina, Araceli, thank you so much for sharing with us about the great work you've been doing in your states. It was so good to get insight into the very different, but also in many ways very similar work you're all doing and goals you're pursuing. Thank you to our attendees for joining today and the great questions you submitted, as well as to our funders who make this work possible. When you close out, there will be a feedback survey. We'd love to hear from you and how we can continue to provide great webinars and helpful resources for you. And yeah, that's it. So thanks again for joining us all today, and have a wonderful rest of your day, everyone.